So good afternoon, dear jury and dear colleagues. Please let me introduce my PhD topic, which is about the effects of maternal factors on the development of orofacial clefts. My name is Márton, and currently I'm a resident doctor at the Department of Oromaxillofacial Surgery. And the two of my supervisors are Gábor Gerber and Gábor Varga, and my SMS is Bianca Golzio. So my vision is to decrease the incidence of orofacial clefts and improve the patient quality of life. And my mission is to indicate those maternal risk factors that play a role in orofacial cleft incidence through the newest scientific data. You can see here that the two of my specific goals. And the first one is about investigating the effects of deleterious habits and maternal health disorders on the risk of orofacial cleft development. It is a systematic review and a meta-analysis. So we know that orofacial clefts are quite common birth defects with an estimated worldwide incidence of around 1.7, 1.8 per every 1,000 live-born babies. And these babies born with these types of anomalies have feeding difficulties. They are often developing conductive hearing loss. They have speech problems, several dental anomalies, and they are associated social and psychological issues. And we know that maternal diseases during the first trimester of pregnancy are shown to play a role in the development of orofacial birth defects. So that is why our aim in that study is to identify those maternal factors that increase the risk of orofacial cleft development. Our clinical question is that, do maternal health disorders and deleterious habits during pregnancy increase the risk of the development of orofacial cleft? Here in this study we use the PEO framework, where our population is pregnant women. The exposures are maternal risk factors such as smoking, alcohol consumption, diabetes, hypertension, and obesity, and our outcomes are prevalence of cleft lip and palate and cleft palate only. We hypothesize that some maternal health disorders and deleterious habits during pregnancy increase the risk of orofacial clefting. And why is it important? Because using our results, these orofacial clefts will be diagnosed to a greater extent, and mothers in the first trimester will be more actively treated in order to prevent these orofacial clefts. Here you can see our systematic search. We use these three databases that you can see with the given search key. And after the flowchart of selection, we have 64 eligible full text for the analysis. Here you can see our outcomes. And the first figure, which is about the effects of diabetes on the development of orofacial clefts. In that analysis, we calculated odds ratios with a 95% of confidence interval. We included 10 papers, and we used 3 subgroups according to the different types of cleft palate. So in the first part, you can see the CLCP. The second is the cleft palate, and the third subgroup is not defined, where these studies did not mention anything about the different types of clefts. And as you can see, highlighted, our final odds ratio is 1.75, which is both statistically and clinically significant. And it means that among those mothers who gave birth to a child suffering from any types of cleft, have 75% greater chance that they were having or they were living with diabetes type 2. The second figure is about the effects of underweight on the development of orofacial clefts. Here we also calculated odds ratios and used the 3 subgroups that you can see in the previous forest plot. And overall, we have the odds ratio of 1.21, which is also statistically and clinically significant. The second figure is about the effects of smoking on the development of orofacial cleft. And due to the big size of this forest plot, I divided into 2 slides. In that case, we used 2 subgroups according to the types of smoking, which is active and passive. And here you can see the active part. We calculated those odds ratios and included 27 papers. Here you can see the passive part of that forest plot. And as you can see below, highlighted, the overall odds ratio is 1.5, which means that there is a 15% greater chance that those mothers were smoking during the pregnancy who gave birth to a cleft baby. The fourth figure is about the effects of obesity on the development of orofacial clefts. Here we used 3 subgroups, but according to the different BMI indices. And overall, you can see that the odds ratio is 1.31, which means that there's a 31% greater chance that the mothers were obese during the pregnancy if they gave birth to a cleft palate baby. So the strengths of our study is that we used subgroups according to the cleft type, which is quite unique compared to the previous meta-analysis in the literature. We investigated more exposures, and we have a quite high population. Unfortunately, we have limitations, of course, in this study, is that the low number of articles in some cases and relatively high risk of bias. In conclusion, we can say that diabetes, underweight, and smoking significantly elevate the risk of cleft development. And as you could see in the first plot, it seems that passive smoking might be as harmful as active smoking. So the implication for practice, for example, is that nutrition, plasma glucose level should be more carefully monitored during pregnancy, and more prevention programs, more effective prevention programs against smoking are needed. And the implication for research is that what could be the difference between the development of cleft palate only and cleft lip and palate, and maybe it would be also interesting to investigate the synergistic effect of these exposures. Here you can see our manuscript status, and our targeted journal is the Journal of Dental Research, which is the D1 journal. Oops. Yes, and the manuscript status you can see here. So my second project is about investigating the effects of different pharmaceutical therapies during pregnancy on the risk of orofacial cleft development. It is also a systematic review and meta-analysis. So just a few things about the background. We know that 14% of pregnant women fill at least one prescription for an opioid analgesic during the first trimester in the USA. And we know from the literature that the odds ratio of developing cleft after the use of anti-epileptic drugs is 6.6. And maternal corticosteroid use was associated with increased risk of cleft lip or without palate. So that's why our aim is to identify those medications that increase the risk of orofacial cleft development. We have the clinical question of, do medications during pregnancy increase the risk of the development of orofacial clefts? Here we also use the PEO framework, where our population is pregnant women, just as before. However, the exposures here are medications, for example, antibiotics, anti-epileptic drugs, steroids, opioids, and our outcomes are the same: prevalence of cleft lip and cleft palate only. Our hypothesis is that some medications during pregnancy increase the risk of orofacial clefting. And the clinical and or research implication is to identify those medications that should be avoided during pregnancy and to decrease the overall incidence of orofacial clefts. Here you can see our systematic search. We use the 3 databases just as before, and you can see the search key. And we are quite in early phase in that topic since we were focusing on the first manuscript. So just to summarize, you can see the 2 ongoing projects. And I would like to thank you for your attention with the quote of Louis Pasteur: "Science knows no country because knowledge belongs to humanity and is the torch which illuminates the world." Thank you for your attention.
Thank you for your presentation. I was wondering what's the case in Hungary regarding taken medications during pregnancy, because the data is from the US, this opioid. Do you know anything about that? What medications do Hungarian women take during pregnancy?
Yes, the most commonly taken medication during pregnancy are anti-epileptic drugs, which might be also a possible risk factor for orofacial clefting. So that's why we are also planning to investigate it or include it into the analysis, that medication.
Thank you.
Thank you for the presentation. I will have several questions. We have time still. The first is about the figure 3, the effects of smoking on the development of the clefts. That's not statistically significant. The confidence interval...
Yes, then I said it wrong, yes, because the active smoking was statistically not significant because you see the confidence interval, but although overall the 1.5 is statistically significant.
Okay, so exactly what is the difference between the 2 plots?
Yeah, so this is one plot, but it is quite big, so I couldn't put it in just one slide. So the first part is just the active smoking. And regarding the active smoking, you can see that the odds ratio for active smoking is 1.28, which is statistically not significant. And the second part of this forest plot is about, or the second subgroup is the passive smoking, which you can see the overload ratio is 2.45, which is statistically significant. And if we combine these two ratios, the overload ratio is 1.5, which is statistically significant.
It's good that now we're talking about the passive smoking, because as I see, one thing that is not controlled for in this meta-analysis is environmental factors.
Yes.
They are not necessarily deleterious habits. Obviously, we cannot help that we are living in a car-polluted, urban area. But regardless, you have quite different papers from different countries. Was it really impossible to stratify based on, for example, pollution or environmental toxicity?
Yes, and that is also a confounding factor in our study, because only just a few studies mentioned that the patient's socioeconomical status or the environmental factors, like they were where the air pollution was higher in that area. So that's why it's also a confounding factor.
And one more thing about the diabetes results. It's not controlled for the management of the diabetes, which is a huge confoundment. How did you manage this?
Yeah, we know that this is also a confounding factor, and the problem is that these studies did not mention anything about whether the diabetes during the pregnancy was controlled or uncontrolled. They only mentioned whether it was type 1 diabetes or type 2 diabetes, and we only include mothers living with type 2 diabetes, and we know that this might be, or this is a confounding factor in our study.
I'm very sorry, one last question about the obesity. Again, it's not stratified for age, because high BMI, when you're a 35-year-old, 40-year-old mother, does not mean the same thing as a 21-year-old obese woman. These are not the same patients. So without stratifying for age in the obesity or underweight, the results are not, they may be statistically significant, but how clinically relevant are they?
Yeah, we know that is also a confounding factor, and we mentioned in the manuscript. And just as I mentioned, these studies or these included papers only differentiate these patients according to the BMI indices and not according to the age.
Congratulations on your presentation. I have a question regarding your second topic. There was a list of drugs, your medications, and I would like to ask if this is a definite list of the medications you are investigating.
No, we are trying to construct the most comprehensible search key. So these are just examples. Yeah.
Okay, thank you.
So
and why folic acid? The counter.
Yes, because that could be also that could be a protective factor.
Yeah. Okay, so that's why. Thank you.